because we've got a great speaker. Um, Joseph Pandit has been with us many, many times before. He's very generous with his information and very thoughtful with our folks, whether you're a family member, whether you're somebody with lived experience. He's a man with a lot of, you're getting it right from the source. He's a doctor of pharmacology. I am not going to sing his praises professionally. I will let him fill you in on his background. We sing his praises as the person that he is, which is somebody that truly cares about you as a family member, as somebody with lived experience. And he has proven that to us over and over the years. And tonight, he will be sharing information that we think you're going to find some helpful tidbits in, and maybe something that'll help you or your loved one in your everyday life. So, Joseph, please take it away.
Thank you, Robin. First of all, I want to check, can everyone hear me okay? I see some head nods. I don't know if your speakers or your volume is all the way up. Again, I'm Joseph Pandit. I'm a pharmacist. I've spent about a decade working as a pharmacist in behavioral health. Prior to that was about 8 years in social work, working with children, with Department of Children's Custody. But again, this last decade of my life has been spent as a clinical pharmacist. And some of you may not have had exposure to a clinical pharmacist in the past. So while I have spent part of my career working part-time in a retail setting, the majority of it, vast majority, has been spent in a hospital inpatient setting. Some of you in the Nashville area may be familiar with the Skyline Madison campus, which is part of that TriStar network. So there's not only Skyline Madison, you may know of Parthenon Pavilion, you know of also the Pinewood Springs program in Columbia, Tennessee. Of course, there's other facilities in that Middle Tennessee area, Rolling Hills, Trust Point, et cetera. Vanderbilt, excuse me, I almost forgot them. So I've spent that time in an inpatient setting with HCA. Currently, I work with a program called Monogram Health. We are doing case management for patients specifically with chronic kidney disease. We have our patients nationwide as we look at helping control hypertension, diabetes. We are actually, as we are now at about 2 years old, we are expanding that. I've been doing some very low-level work, but we're expanding that into behavioral health. So you guys know, your family members know that it's not just depression. It's not just a bipolar disorder, anxiety. We look at so many comorbidities, and we don't always know that situation, the chicken versus the egg. You know, was it depression that created poor diet and now you've got uncontrolled diabetes and hypertension? Or was it a diagnosis of chronic kidney disease and facing your own mortality that has now created this anxiety monster, and you don't know how to quite get control of it? So we know that for our members, behavioral health is a very important facet of their treatment. So Robin, I see the Brady Bunch grid here on the screen. I'm going to take control here, if that's okay with you.
Please do so. We want you to share everything that you can.
Everybody wants to see this boring slideshow here as I post here. So let me do a couple of button clicks so I can get to my screen. Can everyone see that okay, that main screen? Robin, I'll defer to you since I don't see anyone's face any longer.
Yes, we can see it, Joseph.
Wonderful, thanks, Don. So yeah, we're going to talk about the power of pills here. This was my super catchy title that I created some time ago. Managing your medication so they don't manage you. We're going to move forward and just see kind of the things we'll discuss tonight. We're going to talk about very briefly, epidemiology. It's the boring stuff, some of the stats. I will discuss also some of the pharmacology in regards to psychotropic medications. We will talk about some of the drug therapies for these specific disease states. And then we're going to look at some barriers, and that's really where it's going to be the ask the audience sort of situation. I'm going to try to manage this here. Good. I'm switching the screen here. I should have tried it earlier. Okay, I can see the slides now and still see your faces. I've got two monitors up. So we'll look at some barriers. I'll ask for some input from the group. We'll talk about overcoming these, some other general medication info, and then we'll leave some room at the end for some Q&A for you guys. Does anybody have anything they want to ask before I get started? Okay. I will point out as I'm talking and hear responses, I may get distracted because I have a golden retriever sitting here to the left of me who wants to stick his nose in through the armrest of my chair. So I apologize if he gooses me and I jump out of my seat.
And Joseph, before you begin, I will also tell all our participants, if you don't feel like saying it out loud, or if you don't want to interrupt, please put the a question in the chat, and I'll keep track of those, and we'll ask them at appropriate times.
Good idea. Thank you, Don. So I also want to point out before I do any kind of presentation, you know, I might mention medications, I might mention a benefit of one or the other, but just to say it on the record, I am not a paid representative of any of the medications that I'll discuss tonight, or any medications for that matter, manufacturer or marketing group. Again, I am a clinical pharmacist with Monogram Health. So we look at some of the data that's come out in the past 5 years to 20 years from the CDC. We have information from institutes of health. Right now, we're looking at about 10 to 15% of Americans taking a psychotropic medication. And psychotropic, by definition, means mind-centered. So we think about really the common ones. We think about depression, bipolar, schizophrenia, anxiety disorders, ADHD and ADD. But then we think about perhaps sleep disorders. That's something that some people don't think about. DSM-5, and I know there's some more professional staff on our webinar here this evening that could help out. But, you know, the DSM, as it changes from edition to edition, kind of extracts some other aspects of diagnosis, perhaps PTSD, et cetera, which maybe used to be anxiety disorder, and maybe now it's kind of its own thing. If we think about spectrum disorders in regards to autism, et cetera. So we look at a large subset of our population on a psychotropic medication. And then we ask, are there more illnesses, or maybe we're just seeking care more appropriately? And not only are we seeking care perhaps more appropriately, maybe providers are better equipped to identify it and see some red flags when the patient themselves don't know it. Of course, among this time, antidepressants are the most commonly used. Of course, they are a class of medications that are used for things other than depression. We might see it again for certain anxiety disorders, PTSD. We might see some of the older agents that we know as tricyclics used for everything from sleep disorders, jaw clenching at night, to nighttime bedwetting. So, you know, we'll explore a little later about how sometimes the side effect itself can be used as a benefit. The medications for ADHD, and the AP is antipsychotics. That use has tripled since 2010, not only I think because of improvement diagnostics, more and more patients coming out saying, I need some help. I didn't know that there was an option for help. But again, like with antipsychotics, I think we also see a benefit beyond their initial invention, you know, say for schizophrenia. We now see them for anxiety and agitation, depression, bipolar disorder. So they're really kind of the Swiss Army knife of some of the psychotropic medications. As family members, as patients, and perhaps as I've found in the past, some of the people that attend this meeting, they may deal with their own personal medical issues, but we know this impact on the families. We know they can be the people you don't want to see necessarily the entire Thanksgiving. We want grandma to perhaps get enough desserts in her that she takes a nap back in the bedroom. It's the uncle with substance abuse issues. It's all manner of things that can be unpleasant and irritating. You know, we look at untreated and uncontrolled mood disorders leading to joblessness, perhaps changes in the family structure, divorce, etc. We know that these symptoms can cause a poor functioning at critical developmental time for children. So the neurologic aspect of nurture versus nature, is it something actually within the child themselves as we look at neurodevelopment versus exposure perhaps to behavioral issues within the home? And again, like I mentioned at the very beginning of this slide, difficulty in relationships, work life, and a general sense of well-being. So we look at time away from work. We look at, people that are coming in, but maybe not performing to a full capability. They're giving it their all, but is there a better option for them to perhaps perform better at work? And not only for the patient themselves, sometimes it's the caregiver who's exhausted at work because they go home from work to take care of a sick family member. We look at challenges in finding community resources. Where do I go for help? I think that's one of the things we've seen a shift in the last couple of decades is reducing that stigma through organizations like NAMI to put the information out there, phone numbers, resources, providers of all types that might benefit this patient. And again, as we look at stigma, access to care, especially perhaps in rural areas, or maybe in an environment that is not very supportive of healing and health, some of these patients might feel very isolated. So we're already in this decade when this report came out from the Pediatric Task Force. Between 2020 and 2030, we think about 40% of patient visits to pediatricians will involve long-term chronic disease management of physical and behavioral conditions. So we know that we have a culture of improvement of health. We've seen a shift in the dynamic of preventative care, not just enough to treat them once they get in the ER or the hospital. Let's try to minimize that and prevent them from coming in the door at all. So if we look at those measures of well care visits, physicals, the annual visit to the doctor, we're looking at not only addressing things like perhaps childhood obesity, maybe some other medical conditions that would need to be addressed, but we're looking at ADHD, perhaps abuse going on in the home, and just kind of get it addressed earlier on. That whole idea of a team-based approach to care, I've had the opportunity in hospital settings and even currently to work amongst the team. I know we were very quick to think about that leader of the team being the physician, the psychiatrist. But again, I've had the opportunity to work with some wonderful therapists, inpatient and outpatient, some wonderful nursing staff, nurse managers, social workers. We see also in the hospital setting, recreation therapy, music therapy, dietitians. I mean, there's a whole aspect of care that's more than just throwing a pill at it. One thing we do look at is, again, screening, diagnostic assessments. Sometimes family members and patients will be taking a quiz or a survey, ask these questions. There's not a blood draw, a blood sample, a breathalyzer test, an x-ray that diagnoses depression. That was actually kind of a silly, dumb joke I used to ask when I would teach this class in the hospital. I'd say, raise your hand if you guys got your labs drawn. So everybody raises their hand. We're checking thyroid and drug screens and your platelets and your sodium and all these manner of things. How many of you got your depression level or your bipolar level back from the doctor? Of course, everyone's hands go down because we're basing diagnostics not on objective, blood work and x-rays and imaging. We're doing it by the story presented to us by the patient or the family member. And we're using some of these assessment tools, everything from the PHQ to screening for positive and negative symptoms, that scale for schizophrenia, to identify that story and kind of put it into a bucket of where we think that patient fits. Specific treatment, this is kind of that science of the future where we're looking at not gene mapping, but genetic studies to look at how drugs are metabolized in the body. We took a class called pharmacogenomics, that if I give every one of us a medication, most of us will metabolize it or break it down or clear it through the kidneys in a similar fashion. We talk about half-life, a certain amount of time to leave. Well, what if you have a particular cytochrome, is what it's called, an enzyme, that eats that drug up faster? So for all of us here in the room, that drug will last 24 hours, except for Sarah, and that drug is eaten up in 15 hours. But she's only taking the medicine once a day like the rest of us. So she may have a wearing off period. Or some people might have an enzyme that's not as present in normal people. And so instead of taking that medicine once a day like the rest of us, that drug actually lasts a day and a half or 2 days in her system. So she may need to have a half of a dose as opposed to a full dose like the rest. I'm going to skip some of that. I told you the epidemiology was boring, right? All right, so pharmacology. Hopefully the link that you used will also have a link for the exam that comes at the end of this presentation that you will need to advance further in the class. Is that right, Robin and Don?
Yeah, sure.
So, in pharmacy school, we learn this fascinating aspect of medicine and pharmacy medications called kinetics. It's what the body does to the drug. We look at absorption. That is, where is the body entering, or rather, where is the medication entering the body? Most of us would say, well, through the mouth, right? So we're taking pills and capsules, sometimes liquids. But what about lotions and creams? It absorbs through the skin. We think about injectables, be it, the flu shot you're getting right up here in the middle versus something intravenous, eye drops, inhalers. So there's all manner of dosing forms to provide a medication to the best target. Then we look at distribution. That is, where does it go after you take it? I can remember as a kid, if you have a headache, you take a Tylenol. How does it know to go to my brain where the head hurts? It's down here in my stomach, right? If I take an antibiotic and I'm septic and I have bacteria really coursing through all manner of my veins and arteries and capillaries, how does it know to go where it needs to? And that is the finesse of the design of the drug. We base it on chemical aspects, the aspect of protein binding. Is it a molecule that enters the fatty tissues and the central nervous system versus remaining primarily in the muscle tissues? Metabolism is a word we use in regards to the liver. So it's not the matter of, you have a fast metabolism, so you could eat 3 cookies and not gain a pound. This is how the liver breaks down medications. And so if you are using a medication, say like acetaminophen or Tylenol, and you have a poorly functioning liver, again, that dosing of Tylenol may not be appropriate for you because you can't break it down as rapidly. Some medications are also toxic to the liver. Again, like Tylenol, to take too much of a dose could cause damage to liver tissue. Excretion or elimination really is in reference to the kidneys. So these are really medications that are chemical salts, we'd refer to them as. You guys probably are familiar with lithium, some of you. So lithium is broken down, not at all. It is removed from the body 100% unchanged by the kidneys. It doesn't pass really through the liver at all and experience any manner of change. So these are aspects of the body that we have to address. There are differences in how we dose and what medications are appropriate for a newborn versus an adult human being. There are certain changes in muscle volume or muscle density versus fat distribution when I'm treating a geriatric patient. So those doses as well might need to be addressed in regards to how it distributes. So this is a really fantastic graph that we, look at in our very first semester of pharmacy school. You can see a curve. If we look at the very bottom left-hand corner, that is before you take any dose of a medication. So again, let's talk about Tylenol. If you take 1 Tylenol tablet, right, and it begins to dissolve in my stomach and absorb into the bloodstream, passes through the liver, goes where it needs to in the body. But I'm only taking that 1 dose, let's say 1 tablet. It's going to reach a point at which the liver has broken it down and it's now being metabolized and excreted through my body. It's not reaching this infinite curve, right? So there's a point at which it reaches a peak where it's distributing through my body and leaving my body at the same rate. And as that curve travels through like the roller coaster, it's going to leave the body to where I have none left. That makes sense, right? We understand that. I take 1 dose, give it some time, and it's out of my body. There is a window, we refer to a therapeutic range, at which a medication needs to be dosed. And all of these nerds in white coats at the drug manufacturing company do all the research to see what is the effective dose. If I have a headache, the labeling says to take 1 to 2 tablets every 4 to 6 hours. I'm not going to take a little knife and cut 1 tablet into 10 pieces and take that 1/10 of a tablet and expect it to help my headache. It's not enough. And the research has been done. If you look at that slide, the MEC is the minimum effective concentration. That is, that dotted line tells me I got to get above that line for it to work. But if I have a really bad headache, hopefully I know better not to take 40 Tylenol, because then I'm going to hit that top dotted line, which is the minimum toxic concentration. We know that you shouldn't take more than 8 Tylenol tablets in a 24-hour period, because it's more than your liver can accommodate and metabolize. It's like that I Love Lucy sketch where she and Ethel are at the chocolate factory, right? And the chocolates are coming out so fast and Lucy's putting them in her mouth and in the apron, and you know, it's pretty comical. But that's what happens if you try to take more medication than your body can handle, okay? But at the same time, if a patient is missing doses, it's a twice-a-day drug, but they only take it once, or they miss a day, you know, that's when it falls below that effective line, and it's not really working, okay? So then not only is it kinetics we learn about, but dynamics. And this is the real meat and potatoes. What is it doing to the body? So here's some of the lingo we learn if you ever want to read about it. You know, I also give caution as to where you get your information on the internet. Some of it is misinformation or may focus on something that's not necessarily so important, but the mechanism of action is how the drug works. I always teach my students that if you can learn the mechanism of action, how the drug works, then you really have understood the fundamentals of pharmacy. You can, if I know where it works in the body and how it works, I can predict side effects. I can predict drug interactions. So that's very important in understanding some of these drug classes. When you hear the term indication, that is, what is the purpose of the drug? What is it for? Is it for depression? Is it for anxiety? Oftentimes we'll talk about labeled indications. That is what has been approved by the FDA. Sometimes you might hear about a drug being used off-label, and that means it's wasn't approved by the FDA, but it's been around long enough that we saw maybe a benefit of the drug other than its initial design. Sometimes it's appropriate, sometimes it's not. The manufacturer gabapentin got in huge trouble years ago because they were marketing it for off-label indications. You can't go out and tell doctors to use a drug for a purpose, and the FDA didn't approve it for that. So they had to pay lots and lots of money in fines for some shady marketing. Adverse effects, or the ADEs, sometimes referred to as adverse drug reactions, is side effects. Sometimes they're predictable, sometimes they're not. If you were going to take a Benadryl for your allergies, we could predict you might get sleepy from it, right? What we might not expect is for you to have urinary retention and have to go to an ED to get a catheter placed. It's a known side effect, but it may not be something that is seen so frequently that I would counsel you on it, you know, when you're going to take a Benadryl. Drug interactions also, if we look at that mechanism of action as it hits receptors in the body, how can drugs create conflict with one another? Psychotropic meds, we covered this earlier as far as some of the disease states, and we'll go further into this. Theories on psychotropics and how these meds may work. Again, we look at the theory of all of this occurring through the brain. We're still discovering, it's like Star Trek, you know, in uncharted regions about receptors throughout the body, be it cholinergic, histamine, dopamine, serotonin, opiate receptors, cannabinoid receptors. So many studies being done on medications. You know, we see the activity happen through the brain, but what is the impact of a drug that affects the brain if it's also working elsewhere in the body? The origin of illness, a lot of speculation, but we do know that genetics play a large role. You know, we can pass on certain illnesses, be it psychotic disorders or otherwise. We look at time of the fetus, you know, drugs introduced, neurodevelopment, perhaps drugs taken by an individual after birth. You know, what kind of damage is done to the body and the brain with consistent use, chronic use of alcohol or opiates. Infection, we know, can cause disorders. But again, as I use that terminology of nurture versus nature, what does the psychosocial aspect do? You can be born perfectly healthy genetically, perhaps, but what about an exposure to an environment that is not healthy? I will leave it at that. So again, I talked about receptor activity, how these work in the body. It's like Lego pieces that click together. This is not how all medications work. Some are very simple, like Tums. It really is a base that neutralizes an acid. There's no receptor activity. It's just straight up chemistry. But this is chemistry more so at a deeper genetic level here. This is a synapse and two neurons as they are, close to one another. That synapse is the gap between the nerves. And if my body senses a moment where I need, say, a certain chemical like serotonin, there are storage warehouses that will release serotonin. It will flood across the synapse and plug into its receptor, like a plug that fits into an electrical outlet. And when that plug fits into the receptor, we then see a cascade of events. With medications, it could be the heart rate changes. It could be something like movement disorders are resolved or created. We know that some antipsychotics can cause that. But the body has such a magnificent function that it knows when it's had enough of that chemical. It sounds the bell, they unplug and go back into storage for next time. This is actually a serotonin depiction. We know that there's also chemicals in that gap. I believe Robin has heard me use the example of watching Animal Planet. And we know that there's that scene with the gazelles or whatever deer-like creature are hopping across the plains, and they want to get across the river to that green pasture. And they want to go through the water. And there's crocodiles in that water, right? There are certain chemicals in the body that will eat these neurotransmitters like serotonin, dopamine, etc. So there are drugs that are designed perhaps to allow safe passage for that chemical to cross that synapse. We know these as, you may have heard of monoamine oxidase inhibitors, MAOIs. So these are medications that can be very useful for certain disorders. If you'll excuse me for just a second, I'm coming right back to you. Robin, I don't know if you knew that I'm wearing an insulin pump these days.
No, I didn't.
Yeah, that's a whole bunch
Okay,
of
well, let's pump you up.
It's vibrating right now. Let's take a commercial pause while Joseph addresses his insulin pump.
Everybody, I just want you to think of like Arnold Schwarzenegger on Saturday Night Live.
You're dating yourself, Robin.
That's okay. I've been here a long time.
So moving on. So we look at the therapeutic effects of medications. These are not going to cure anybody. They will relieve or decrease symptoms. They may prevent or delay the return of symptoms. And they are not, I cannot repeat often enough, to be used as sole treatment. We have that culture of wanting convenience, a quick fix in some occasions. We don't want to do the hard work. And so very frequently these illnesses are combined and intended to be combined with things like cognitive behavioral therapy, DBT, other type modalities of treatment, exercise, diet, journaling, even beyond therapy. And there are some times where medication really is not the best thing for the patient. It's very desirable, again, to want that convenience, but sometimes the medication is just not it. So depression, I'll kind of go through these a little more quickly. For anyone that has never been clinically depressed, it's kind of hard to envision it. We look at different gradients. It's not just black or white, you have it or you don't. There's some gray areas. So MDD is clinical diagnostic, for major depressive disorder. But then there are certain criteria you must have to obtain that diagnosis. If you do not reach full diagnostic for MDD, we might talk about a dysphoric disorder. Again, this is some older data, goodness, 20 years old, but we think about the Prozac Nation when the SSRIs came out. Some of you might remember that. I kind of still remember the cover of Time magazine as it came out. There is a black box warning, which is a neon light that says there is something that can go terribly wrong with this medication. And for all antidepressants, there's a black box warning for an increased risk of suicidality in children up to the age of 24. So we know that 24-year-old is not a kid, but there is that warning, and we'll come into that a little bit more. The first drug classes I want to talk about, and we'll skim through these, are some older ones. The MAOIs really are not used very much anymore. These monoamine oxidase inhibitors, going back to my Animal Planet example, these are basically muzzles for the crocodiles in the water. It allows that serotonin to make safe passage, to plug into the receptor and come back into storage safely. The tricyclics, we don't use for depression much anymore either. They are very effective, and let me not miss that point. They are very effective for depression, but the side effects prevent them from really being first line therapy. Buzzed again, excuse me.
Mhm. Yeah, when you're buzzing, you just answer the call.
We're all good. So we can, though, use these for some benefit. If we look at the ADE, that is the side effects, they can be sedating. It can create orthostasis. That's that feeling of lightheadedness. You know, when you bend over to pick something up and stand up again, you kind of get a little woozy. That's literally the blood rushing out of your head. Some medications might predispose a patient to having that occur as we look at some cardiac changes. They can be anticholinergic. And when I say that, I want you to think about Benadryl. Think about the things that can happen with Benadryl. Dry mouth, dry eyes. I mentioned urinary retention earlier. It can cause sedation. So we look at that first side effect. With the MAOIs, dietary restriction, which is probably one of the largest reasons we don't use this class anymore, because there are certain foods and drinks you can't have anymore, and even certain medications that aren't safe to be taken anymore. So if you ever look at a medication bottle, a box over the counter, it says, do not take if you are on an MAOI. And if you're asking yourself, am I on an MAOI? You are not. Because if you are on it, your doctor and your pharmacist would have browbeaten it into you that you are on an MAOI and don't take anything extra. And here's the food and drinks you can't have. So you'll know it when you're on it, but most doctors aren't using it anymore. The SSRIs, the selective serotonin reuptake inhibitors. Remember that bell I mentioned earlier in that example where the serotonin unplugs and goes back into storage? This is the snooze button. These are reuptake inhibitors, the reuptake being going back into storage. So it inhibits that call back into storage. We know these, we've heard of these. Some of you might be on them. These are all the generic names on the left, the brand names on the right. All of these, except for Vibrad, vilazodone, are available generic, okay? Then we look at the idea of depression being very debilitating, suicidal thinking at times, changes in appetite, sleep, energy, feelings of guilt. Sometimes there's actually physical slowing we call psychomotor retardation or psychomotor agitation when a person might get very fidgety and irritable. So we look at all those aspects of depression and criteria for diagnosis. Another of these really is that important aspect of energy. We could start you on a medication and your mood has improved, your appetite has improved, but you're still lacking kind of that motivation to get up and shower and take care of hygiene and, you know, engage with your family and interact with coworkers. So we look at now a combination neurotransmitter drug here, which is the SNRIs. So these impact not only serotonin, but also norepinephrine. So I know everyone in here has heard that term. You probably have heard of epinephrine. Does anybody know what the street name for epinephrine is? Most everybody's got a blank screen. I see a couple of head shakes.
Yeah.
Epinephrine is adrenaline.
Right.
So you've heard of EpiPens. That is literally a shot of adrenaline. And what happens if we get adrenaline? It's that rush, right? Our lungs open, our brain becomes focused, our heart rate increases. We think about the fight or flight or freeze responses that can occur with adrenaline. This medication can be beneficial for patients that need some of that increased impact of norepinephrine within the system. So these are also available, some generic, some are still brand only, like Prestique. Fetzima is also available only as brand. So I use this idea of et tu Prestique, so throwing out some Shakespeare, Julius Caesar at you. If you look at these first two drugs, venlafaxine, desvenlafaxine. In organic chemistry, there's what is it called? The letters in the beginning of the word versus the shoot, I can't. The word's escaping me, Robin. I can't even think of
the prefix versus the suffix.
Prefix, yes, prefix.
Okay.
There you go. I kept saying pronoun. I've been hearing about pronouns so much. Prefix. Prefixes such as des and nor refer to an aspect of a base molecule being removed. So we think about epinephrine, right? And a little piece has been broken off through metabolism, and it has an active metabolite, which is norepinephrine. When we look at how a drug will pass through the liver, sometimes I'm giving you a benign inactive drug. It passes through the liver, and now it's an active metabolite that actually does all the work, right? We call it a prodrug versus an active metabolite. Sometimes I give you a medication that's already active. It passes through the liver and becomes another active metabolite. Such is the case with venlafaxine. We provide that as a Fexer or venlafaxine molecule. It's active, and when it passes the liver, it becomes another active metabolite. The manufacturer of a Fexer knows what happens when it passes the liver. So when a Fexer was about to lose its patent, they now marketed in a bottle the active metabolite and sell it now as a completely different drug. They know what it is. They have all the research on it, but now they can sell it as a brand name. Very similar with Lexapro. If we think about molecules, and you might have drawn them on a notepad in a science class at some point, they are two-dimensional. But if I put them in outer space, they are three-dimensional. That's how molecules exist. So these molecules of drugs in a product, be it a tablet or a liquid or an injection or whatever, exist as mirror images. Okay? Now, sorry, Robin.
Yeah, question on the Effexor. So when you say it comes in one way and goes out another, is it like an opposite? You said it mirroring. So is it opposite effect, or is it just an extension of the strength of it?
An
Yeah.
extension. So
It's
if
an
we can make
extension.
it a little more simple, if I take a Fexer, it becomes Prestique in my body.
Okay.
So if I'm taking Prestique, I've skipped the Effexor first step.
Okay. And so so did they do this with medications when they want something to be either long acting or, short?
Perhaps sometimes, primarily they do it for money.
Oh, okay.
There
I would
may
never guess that they would ever do that. Yes.
Can you imagine what in this economy? There are occasions where we know that altering the molecule may benefit in reducing a side effect.
Okay.
So, later on we'll talk about risperidone, which has an active metabolite called paliperidone, which is Invega. So again, beginning and end, active versus active. We know that there are very mild, minor changes in some of the side effect profile in Invega versus risperidone, but for some people, it's really negligible and isn't worth the cost. The idea with Lexapro is Celexa has the mirror images of the molecule, right? Left side, right side, if I'm thinking about hands, right? I've got 4 fingers, thumbs. I could put my left hand into a right-handed glove. Won't fit just right, but it fits, right? It kind of does the job. We know that we can isolate a molecule and know that the left side actually is much more effective than the right-sided molecule. There are chemical names to it. All you really know is that Lexapro is the left-handed isolated molecule that's contained in Celexa.
Okay.
Celexa has left and right. S-citalopram is the isolated left side. So again, it's a way for a drug company to make more money for a brand name product. So the SSRIs, SNRIs, again, we work on serotonin, norepinephrine. One important point for patients to understand is having appropriate expectations. The patient comes into the hospital actively suicidal. They want to hurt themselves. They are so depressed they can't function. We look at substance abuse, comorbidity. We have to help them understand this could take weeks to work. So we house them perhaps in a safe environment, provide them safe resources, phone numbers, maybe a temporary as needed medication to address anxiety, sleep, appetite until the medication really kicks in. Again, the indications, the purposes, depression, anxiety, obsessive compulsive disorder, perhaps PTSD. There are adverse effects to these drugs. These are a very safe class of medications that, again, cause a skyrocket in usage in the last 20 years. But if it's a side effect that prevents somebody from taking the med, then that is not the best one for them. Or perhaps there can be some other ways to address the side effect. Serotonin syndrome can almost appear like a seizure, not really the convulsive type, but the locked muscle type. It can cause sexual dysfunction. We have a very quiet culture when it comes to sex. It's embarrassing. It's kept in certain circles. It's only be discussed, among certain people. But it is a very strong reason why some people don't take these medications, be it erectile dysfunction, libido changes. They were depressed. They couldn't be intimate with a partner. Now they're feeling much better and a bit more romantic, but now the plumbing doesn't work. So that can be a problem. And again, a conversation to be had with the doctor. I mentioned generics versus brand. Again, the majority of these are available generic, so cost would be minimal compared to a brand name counterpart. Some of the more commonly used miscellaneous antidepressants, which have mechanisms of action different than the others I've previously mentioned, would be bupropion. We know most commonly as Wellbutrin. The same chemical is marketed also as another drug called Zyban. Anybody know what that's used for? Same drug. It's for smoking cessation. It's not Chantix, it's Wellbutrin, but they market it under a different brand for smoking. Mirtazapine we use, it's a very effective drug for depression, but like the tricyclics I mentioned with the side effects, this one can cause sedation and weight gain, which can be useful for a depressive patient who has insomnia and has lost a lot of weight due to lack of appetite. This may be the med for them. Trazodone, also a very effective medication for depression, however, usually makes people so sleepy they won't take it. So we might use it for sleep. 50 milligrams, 100 milligrams. We're looking between 300 to 450 milligrams of trazodone for depression. And I bet most of you had never even heard of that dose. So it's very rare that we would see that medication used for depression. Any questions at all before we move forward?
And,
All right.
and do speak up because we can't, and Don is monitoring the chat. So if you'll put a question in the chat, but since we can't see the full screen, you may need to speak up if you have a question.
Sure. Yeah, thank you guys. So schizophrenia, I will point out the very last bullet on this slide, it is not multiple personality disorder.
Right.
I heard that from the time I was a kid. That's dissociative identity disorder, DID. That is something else completely different. Schizophrenia affects about 1% of our population. In fact, about 2% of our population actually takes an antipsychotic. I think that number is probably outdated since we've seen some other benefits and indications for it. But schizophrenia is characterized by positive and negative symptoms. I teach this to students. Let's talk about positive, those things that are added, they're extra, say, versus what a normal human being might be. What's extra? Well, psychosis, hallucinations, auditory, tactile. We might hear things, see things, feel things. Also, delusions, paranoia. We might actually see in schizophrenia then negative symptoms. What is subtracted? What's missing? Maybe a positive mood. So the older medications, we think about Haldol, Thorazine, flufenazine, very effective for schizophrenia, but didn't treat as well the mood component seen in schizophrenia. Disorganized thought and speech. We use certain terminology like word salad, where someone might be speaking to you using real words that have absolutely no context whatsoever. They're alterations in the brain that make them think they are communicating clearly with purposeful thought behind it, but yet you're hearing gibberish. In some cases, severe cases, which I've seen a few times in patient, is catatonia. So we would see a patient, and I don't know who all actually is seeing my screen, but we would see a patient facing a wall, non-communicative. We could take their arm and raise it, and it just suspends there in midair. They don't think you have to physically almost put it down, or they may very gradually put it down. So that's another presentation of a type of schizophrenia.
Joseph, quick question. For what you just mentioned with the catatonia, if they should come across someone in catatonia, and we've had a couple folks within our groups that have one dealt directly and one dealt with a family member. If they see an arm or something like that, should they ever try to put that down or force that down or anything?
Sure. I wouldn't know about necessarily forcing it, but yeah, I think you could ease them down.
Gently.
Certainly.
Okay.
Yeah.
Okay.
For the record, we go into the use of antipsychotics in schizophrenia. The treatment of choice for catatonic schizophrenia is actually ECT, or electroconvulsive therapy. Medication-wise, we would use benzodiazepines like lorazepam or Ativan. So we look at the parts of the brain where we might see evolution of psychosis, and these are actually specifically tracts where dopamine plays a role. We look at these tracts as far as how we seek target for our medication therapies. Now, interestingly, we see the nigrostriatal, okay? This translates really also the nigrosubstantia, which is the portion of the brain known as the black stuff. If you were to dissect a brain, it's the darker matter within that portion of the brain where we see dementia and perhaps even Parkinson's type dementia. We look at the tuberoinfundibular tract. It's easy for me to say, right? I've practiced it so many times. These are medications that also regulate part of our endocrine system. And it's important to understand these portions of the brain where dopamine acts because it creates some of the side effects of these drugs. So again, whether it be movies or family members or yourself, we've heard of some of these. Thorazine, Haldol, right? Did I put, yeah, there's perfenazine with the asterisks. I'm going to mention the Katie trial shortly after the next slide. These medications work on dopamine. They actually block dopamine. These are the atypicals, or what we refer to sometimes as the second generation of antipsychotics. So these are working not only on blocking dopamine, but some of the subsets of serotonin receptors. So we all know Abilify, clozapine, right? Latuda is one of the newer ones. There's Invega, Geodon as well. Fanapt we don't see as often. I marked Saffras here. It's the lone antipsychotic that is actually sublingual, so to be placed under the tongue and take some time to absorb. So I mentioned that mechanism of action, what it's used for. I think I mentioned that early on in the presentation. The side effects. This is why our patients stop taking it. Doesn't matter how well it works for the voices, the paranoia, the delusions, they quit it because of the side effects. So the best one for the patient is the one they will take. Movement disorders. I mentioned the aspect of Parkinson's disease, how dopamine blockade can impact that part of the brain. So patients that take some of these antipsychotics get tremors, very Parkinson-like. Chronic long-term use, we might even see kind of the familiar head bob, the foot shuffling that can translate into a more debilitating illness. So we have to make sure we are monitoring for that. Some of the newer agents in that second generation work also as antihistamines. Again, think about Benadryl. They can be sedating. They can cause significant weight gain. Seroquel, Zyprexa, clozapine. I've had patients gain 50 to 100 pounds. And that is very objectively good rationale for a patient to probably want to stop taking it. They can't fit in their clothes anymore. right? They've developed a metabolic syndrome. They've got diabetes now and high cholesterol. Now we look at some other meds, be it Geodon, perhaps clonidine, cardiac effects, seizure risks. So as good as these drugs may be, we may identify, again, rationale to change a medication. Extrapyramidal. It's a portion describing the brain that's causing movement disorder. Think about the movement disorder with first-gen metabolic issues like weight gain, cholesterol, being the second generation. So again, I want to also mention this as a large statement when it comes to the Katie trial. So this was a trial developed to explore when the newer agents came out, all the drug companies that were producing these drugs said, hey, let's put it on paper once and for all that we're better than the old stuff. All these millions of dollars they sunk into the research and the trials only to find out they are indeed not better than the old stuff. They used this scale to determine psychotic, the positive and negative symptom scale. They used all the new ones at the time. So some of the newer agents on that last slide were not available during the trial, but they compared it to perfenazine. And they were equal in controlling symptoms. Where they were not equal, they were looking at how long did it take for somebody to quit taking the meds. Everybody's going to stop the meds. What's the one they took the longest? And that particular trial, it actually was olanzapine, which is Zyprexa. It's very well tolerated, but has significant effects on weight gain, which is why most people at the end of the day quit taking it. I put in here the idea of abuse in some populations. I don't know if you've heard this in the news or anything. People like to get high. They want to get stoned. They want to alter their mind. I remember still a professor from school who told us he would work in the ED. He would have people coming in faking an allergic reaction so they could get a Benadryl shot because they thought getting kind of woozy and sedated meant they were high. I mentioned the antihistaminergic effect of these drugs. So believe it or not, antipsychotics, we think about Geodon and some of these, are highly sought after in prison populations. So outside of your run-of-the-mill street drugs, cocaine, heroin, etc., people like to take these meds because what better way to spend 5 to 10 years in jail than asleep, right?
Hey, Joseph,
Sure.
Go ahead,
we've had,
Robin.
I was going to say, we've had a question.
Yeah, that's why I was going to interrupt too. Go ahead, Robin.
Thank you. Thank you. And welcome back, Heather Farina. Nice to see that name. What current research have you heard on patients taking some of the psychotropics for years and then having organ problems such as lithium or clozaril?
Organ problems. So lithium, I mentioned, I think early on, and we'll get to some of that in bipolar. It can potentially cause some kidney damage. There's another effect we call diabetes insipidus, which is unfortunately a bit of a misnomer in the sense that people think about, type 1, type 2 diabetes, insulin. Diabetes insipidus is related more to ion exchange, salt exchange in the kidneys. Could cause fluid problems, and if we're starting to see impact in kidney function, then a person will be removed off that. If they are taking it long enough without proper monitoring, then it could be, a lifelong can't return from it type of injury. Clozapine, all the antipsychotics are fully metabolized by the liver. There is no kidney impact. But as far as organ damage, we wouldn't see them necessarily damage the liver. We may see cardiac impact. So they can impact the way we see electrical impulse in the heart. Geodon is one. It can cause alterations in an EKG, arrhythmias. Clozapine can do the same. So these are things that are monitored when done properly by a provider. They may get what's called a baseline. Hey, before we start this med, let's check your EKG, see where you're at. We might check it once a year unless there's something that presents that makes us need to do it sooner.
Thank you.
Yeah. So bipolar disorder, manic depression, right? North Pole, South Pole has to contain the aspect of, and I need to check a clock here real quick. It needs to contain the aspect of a depressive disorder. But we look again at schizoaffective. I mentioned schizophrenia with depressive type symptoms. You may also have a bipolar disorder with psychosis. Here are your classic mood stabilizers, lithium as a salt. The others are actually traditionally anticonvulsants used for epilepsy. So we think about Depakote, Tegretol, Lamictal. Trileptal gets used sometimes, but it is really not very effective for mood disorders. Again, lithium as a salt, sometimes the body has to decide what a salt to keep hold of. And ionically, chemically, it may grab onto lithium more than sodium. Remember that graph early on with the curve, the roller coaster, the therapeutic window? For most drugs, it's pretty wide. I can give you 50 milligrams. I can give you 450 milligrams. Think about trazodone. Seroquel, I can give you 25. I can give you maybe 1,000 milligrams and you're doing all right. Lithium's therapeutic window is a much more narrow margin. Things like dehydration, salt intake, any kind of medication that could impact the kidneys, think ibuprofen. Think about certain blood pressure medicines like lisinopril can impact how lithium is cleared from the body. And if I'm not removing it in the expected rate, it builds up and all of a sudden I'm in that toxic or above that toxic line. Anxiety, this is one of those I mentioned earlier where this may not require pharmacologic therapy, okay? Feelings of nervousness, agitation, to much more severe type events where we look at panic disorder, agoraphobia, obsessive compulsive disorder. It can be very crippling. The chronic drug of choice for patients with anxiety is actually an now an SNRI. So we might use Zoloft or Paxil for some of these medications. But for those moments of panic, what I don't want to do is give you a medication that might take 8 weeks to work. So we might use in the moment type medications like the benzodiazepines or benzos we call them. Xanax, Valium, Klonopin. There are some other medications we might use, buspirone or Buspar. This is to be taken scheduled basis, not as needed. It's one thing I had to counsel my patients on so much because a doctor might switch them from Xanax to buspirone and not tell them, hey, now you need to take this every day or 3 times a day. Then a patient's not doing that, they get panicky, take this, it doesn't work, they end up in the ER because there was a miscommunication there. Some of the antihistamines, we use hydroxyzine, or Vistaril you may have heard, or even Benadryl very, very frequently. In the essence of time, I'm going to skip through some of this and kind of come to some of the purpose here. We said this, treat the acute illness, perhaps prevent future breakthrough symptoms and episodes, and ultimately improve the quality of life of our patients. For some of these meds, we're going to monitor drug levels like lithium and Depakote. We want to keep you in the appropriate therapeutic range. CBC, CMP. This is some lingo for lab work. I might need to watch your platelets in regards to, say, Depakote. I may need to watch your neutrophil count or white blood count with, say, clozapine. The CMP is a metabolic panel. I need to watch your electrolytes. I'm going to watch your sodium. I'm going to watch your liver function, kidney function, all right? I don't want to have to stop this drug, and I don't want you to experience the side effects from it. Pregnancy. These antipsychotics, some of these are not actually appropriate for someone who is currently pregnant. We do know that there's changes not only in body structure, volume of water, fat distribution, but it could also be unhealthy for the fetus. I mentioned metabolic syndrome in regard to the antipsychotics. Metabolic syndrome specifically is a change in waist circumference, changes in blood glucose, changes in cholesterol. Okay, it's that truncal fat, it's belly fat. And it's not just being overweight head to toe, it's that midsection that we know increases greatly a cardiac risk for heart attack or stroke. Interestingly, I talked about enzymes earlier, the way the liver might break a drug down faster or slower. Smoking actually contains an enzyme that may make a drug wear off faster. So you want to talk to your doctor if you're on one of those. We would see patients that we would stabilize on a certain antipsychotic, knowing they're a smoker, and the doctor would increase the dose right at discharge because the patient's going to fire up that lucky smoke as soon as they get in the parking lot. We talked about orthostasis, dizziness, lightheadedness. If a patient says, doc, I take this drug and I get super sleepy when I take it in the morning. Well, if it's a once a day drug, talk to your doctor about switching it to night. It could be a little trickier if it's a twice a day drug. Maybe you take a lower dose in the morning and more at night. Vice versa. I take it at nighttime and it keeps me awake. Well, again, talk to your doctor about that. Of note, a couple of these, like the benzodiazepines, are controlled substances, very specific rules on refills, securing it, how the doctor provides the prescription.
Joseph, we have a couple questions in the chat. First one is, does vaping have the same effect on AP levels?
So my first answer will be, I don't know. I don't know. I wish I had a better answer for you, but I don't know, I'm afraid.
Okay.
I can look into that and then email the group.
That'd be wonderful.
Yeah.
Right. Second one is, would resolution of positive symptoms such as paranoia and hallucinations with a medicine like Zyprexa be diagnostic for schizophrenia in someone resistant to care but given Zyprexa during unrelated hospitalization to allow care to proceed?
So psychosis, be it paranoia, delusions, hallucinations, is one of the major diagnostic criteria of schizophrenia. But we think about what we call rule outs. What are other things, other medical issues that could cause psychosis? Drugs, LSD. We think about the hallucinogenics, mushrooms, peyote, etc. Some of the bath salts, infection. We had a geriatric unit. If I have an 85-year-old woman with a UTI, she may present with psychosis. It's not necessarily appropriate to start her on a regimen of Zyprexa or Abilify when I need to give her some antibiotics. So while it would be, that alone is not. We look at disorganized thought really as being a hallmark criteria, orientation to time and place, duration of the symptoms, other compounding factors. So yes, it is a large part, but it is not the sole criteria for schizophrenia diagnosis. Did I get that okay?
Yes, there was a thank you.
Now, you know what? Again, as we're looking at the time crunch here, I had this whole thing planned out where I was going to get feedback from you guys as far as adding to this list, barriers to adherence. Well, guess what? I don't have time for that anymore because I've already got the slides made, okay? We're just going to do that instead.
Well, and I think, Joseph, you're getting some of the questions in
Good,
and
good.
responding to them.
Uh-huh.
And so I think that is helpful. So we'll go to your slides, but we'll also get, what's in the chat. And so even if you're not encouraging that to come out, we'll still be getting it.
Wonderful.
And we do have a new question. Do doctors ever prescribe, and forgive me with pronunciation, bupropion as needed, or are patients making this up?
They are making it up.
Okay.
Now, I don't know the whole situation. I will just clarify, it is not to be taken as needed.
Thank you.
So we look at very common barriers to adherence. I have heard these over and over again. So if this is something you guys are feeling, if this is something that you've heard your family member, significant other state, they are not alone. If you'll see that very last bullet point, if NAMI does anything, they reduce stigma. They want you to know you are not alone out there, right? So again, understanding the disease. Now, I imagine that's a lot of what NAMI is doing with this particular group, that as you work through this program, understanding the illness. Does it get better? Does it get worse? What can I expect to see? How long does it take? About prognosis, right? Cost, adverse effects, and I'm going to advance because I'm talking about these individually. The prognosis is lifespan. Patients with schizophrenia actually experience a level of brain damage that they don't live as long. We know from the research that a patient that is stabilized on an antipsychotic has the same lifespan as someone without the disease. Options for treatment. Again, we discussed there are non-pharmacologic measures to be taken outside of a pill. Sometimes you don't need a pill at all. Medication alone? Probably not. Honestly, probably not. How quickly will they work? Well, in some cases, they can be pretty rapid. If I'm in a panic attack and I take a Klonopin, it's going to kick in pretty quickly. If it's my antidepressant, again, maybe 2 months. And that's if I'm at the right dose. How long will I need to take a medication? For psychotic disorders, probably the rest of your life. And that is something that I think does not sink in with some patients. Depression, we do see often as self-limiting. We do see very chronic, debilitating depression. We have to question, have they attempted the right treatment modality? Often they're taking pills and not going to therapy. They're not addressing other environmental factors. They're in an abusive marriage. They've got a home life that's not being addressed. Trauma from the past not being addressed. A pill won't fix that. Cost as a barrier, yeah, brand versus generic. In short, if I'm a drug company and invent a drug, the government says I've got a patented copyright on this drug, approximately 10 to 15 years. Nobody can sell this molecule, okay? But when the patent expires, any drug manufacturer can make and use my recipe. It may look different. So I've used the example in the past. If I invented the cheeseburger and the government said nobody else can sell it, by God, I'm going to sell it for $25 a piece, and open up all my stores where you can get it nationwide, because nobody else can sell a hamburger or a cheeseburger. But as soon as my patent expires, anybody can open up a hamburger shop. They can make it look and taste just like mine. I can't sell mine for $25 a cheeseburger anymore, because someone else is going to put it on the 99-cent menu, and I'm going to lose all my customers. So that's what a generic drug is. It's an expired copyright, and now you have multi-manufacturers making the same product. How many places can you go buy ibuprofen? Walmart, Kroger, CVS, Walgreens, Dollar Store, truck stops, and they're all made by different manufacturers. Insurance, we talk about formulary. What does your insurance actually cover? Generics will always be tier 1, that is level step 1. Some they'll say, hey, we'll pay for it, but it's a higher copay. Your generic is $5, brand name drug is $25. You go to tier 3, maybe a level where they say, okay, we'll pay for it, but we want your doctor to send us a letter that says you've tried stuff in the first level and the second level before we pay now for the really expensive stuff. And that they're expensive because they're brand name. And again, these drugs are not really better than one another outside of a side effect profile. The patient assistance programs, PAPs, this is all about prescribing habits. If you have a drug rep that goes to a doctor's office and says, hey, this is our new medication. By the way, you smell that? That's the Olive Garden I brought for your staff here in the office. Let's talk about this new antidepressant. It's not better than the rest, but here's some samples you can give your patients. Here's some coupon cards. They can use their insurance, so it won't be more than $5 a month. And if the patient goes to the pharmacy and they find out this drug is really expensive, and expensive is very subjective to the patient. It might be $800, right? It might be $5, which may not seem like a big deal to some of you, but could be very problematic for someone on 20 medications, or they're on 5 and the husband's on 5 and the kid's on 6. $5 each gets very expensive. So what the drug company does not want is the doctor to be getting a whole bunch of angry phone calls about how expensive the drug is. That's why they provide things like samples and coupons for that patient assistance, because the doctor deals with enough angry patients, they're going to quit prescribing it. So let's give a manner of access for that medication. You have some programs in Tennessee like the Dispensary of Hope that provides low cost, no cost medications. Talk to your doctor. They can get access to what's in stock at those clinics and pharmacies to provide medications. CoverRx for uninsured, low-income people has a very limited formulary, but medications, again, that are very low copay. It's about a one-page application. What's your name? What's your phone number? Do you live here? Do you make less than this amount of money? All right, you're approved. That's how CoverRx works. The two new ones that I just added were some other resources for Amazon Prime. If you got a Prime membership, you might get a good deal on a mail order. Mark Cuban, he's got a new thing here, Cost Plus. So we look at some of the pricing structure. You might find, you just go online, look at their catalog, plug your drug in, you might get that $19 medication for $4 shipped right to your door. General pharmacy info to know, when are they open? COVID has thrown it into complete upheaval. You go to the pharmacy, well, they used to be open at this time. Now they're not. Now they've got a lunch break, thank goodness. I mean, I can remember working 12-hour shifts and I've never got to sit down, much less use the restroom. Some places are closed. What's the weekend hours? How much time it takes to actually prep a med. We're so used to walking up, dropping off prescription, in that routine, gives about 30 minutes, 45 minutes. I'd rather not say that. I'd rather be able to say, come back in 2 days. Okay, you've had that prescription bottle, right? You're out of refills. You've had 1 or 2 pills, decreasing every single day. You should have called it in earlier. So if you're in a hurry, call it in ahead of time, okay? These days, most prescriptions are filled off-site, okay? A lot of you didn't know that. Kroger, Walgreens, CVS, they're using off-site warehouses with pharmacists and technicians and big robot machines filling these bottles, printing the label out, and shipping it to the pharmacy. So a place like Kroger's might get that delivery, every other day. So if you're giving that lead time to the pharmacy, it's not a problem. And it gives more manpower for the people on site. Someone just getting out of the ER, someone that's coming with a new prescription from the Minute Clinic, rather than the person who has, again, had this refill every day for 3 years and now comes last minute because they're out and they want it right now. Side effects, what can we do? Number 1, report it. Please don't stop taking the med without talking to the prescriber. We talked about that window of safety, that therapeutic range. What can they do? They might change it. It's not going to be good for you at any dose, right? Sometimes you're at 100 milligrams and you're above that line, the toxic line, which doesn't always mean death. It could just mean side effects. Let's take you down to 50 milligrams. The problem with that could be I've lowered the dose to the point where it doesn't work for you anymore. Because again, you may be in the therapeutic range, but not at the dose for what you need. Sometimes we look at what's called a prescribing cascade, okay? We might see where we start you a drug, it causes a side effect. Let's give you another drug to treat the side effect. If I'm giving you a drug called Haldol, you don't want to gain weight. If you have a psychotic disorder, well, guess what? Now in a couple of days, you've got the shakes. Maybe some tremors. Maybe you feel muscle tightness and a locked jaw. We're going to give you a drug called Cogentin or benztropine to treat the side effect because I don't want to stop the Haldol. Sometimes it's appropriate. Sometimes you end up like a patient I've had this week who's on 44 medications because she's on so many, it's absurd. She's got 12 doctors. Nobody knows what the other one's prescribing, and they're all starting meds to treat side effects. With these medications, you are not cured. It's only hopefully going to remit the symptoms, kind of help them subside. I remember in my residency training with one of the doctors, we were discharging a patient who was still hearing voices. And I thought, well, that can't be right. Doc, why are we letting this guy out the door? He's like, he might always hear voices. As long as he knows they're not real, we're good. So, that may be the baseline for that patient. Again, looking at an acute versus chronic illness, it's not like having an infection and I take antibiotics for a week. This may be lifelong. My meds don't work. Well, have you taken it long enough? I started my antidepressant yesterday and I'm still suicidal. Well, we got to give it some time. Let's look at some of your other needs that maybe we can address right now while the antidepressant is kicking in. My meds don't work. Maybe it was a misdiagnosis. Okay, the question earlier about a psychotic disorder and being criteria for schizophrenia. Maybe we're treating the wrong thing. We have what we call rule outs. All right, have to identify really the origin of it. Now, it may look like schizophrenia, and I give you medication and it may respond initially, but not fully. Maybe it's a bipolar disorder with psychosis. Bipolar disorder utilizes an antipsychotic, but probably also a mood stabilizer like lithium. They may not work if I'm giving alternating or rather interacting drugs that could compete with metabolism. It negates the effectiveness of drug A because I've given drug B for your blood pressure. So we need to make sure that all the prescribers know everything else you're taking. Possible underdosing. If I start some of these meds, it's going to be at a low dose to avoid some of those side effects. I know that the end goal is probably to get you to about 300 milligrams of clozapine. I'm going to start you at about 12 and a half or 25 because I don't want to cause a seizure or cause a cardiomyopathy. I'm going to work my way up. At the hospital, we may start you on it. You start to see some improvement. Again, I know that end goal, but you no longer meet criteria for admission because the insurance company wants us to kick you out, right? You're feeling better. You're not an acute illness. You need to see your doctor on the outside to finish that upward titration of your dose. Well, you feel better, so you don't ever go follow up and see your doctor, so you stayed on the same low dose. Then your symptoms come back, you don't know it, you're delusional, you're paranoid, you're back in the hospital. I'm on too many pills. Maybe you're on 44 medications and we got to get you off some of them. Maybe not. Some of the guidelines for blood pressure a few years ago, it said, quit telling your patients to quit eating salt. If they come in, they've had a couple of readings of high blood pressure, they need a pill. And then after that, they said, you know what? You're just delaying the inevitable. If you're going to diagnose them with high blood pressure, you probably need to go ahead and start them on 2. All right, we're looking at reduction of symptoms, reduction of mortality, that is death. Let's keep you out of the hospital. Again, the idea of a prescribing cascade. I started you on a pill to treat a side effect. What if we just change the first drug? I might be able to get you off some of these other medications.
Hey, Joseph.
Maybe, yeah.
What about DNA testing for metabolism for the drugs that you're suited to?
That is very possible. You know, you could talk to your doctor. The doc may say, I don't believe it. And it may just be old dog, new tricks. You can Google it, look up genomics or genetic testing, medication. There's probably a local lab that you could go to and get a lab report. Mm-hmm. Very possible you don't find anything. You might find some information to take to your doctor, and you see that you're on a medication where your medication may not be effective because your body's chewing it up too fast.
Thank you.
We look at reducing frequency. You know, some of these medications are available long acting. Instead of the 3 times a day you take a pill, maybe there's a once a day extended release. Some of these antipsychotics are also available in a once a month shot. The Invega product has actually an every 3-month injection. We want to reduce that burden. It's also very good for the patient who says, I'm not sick, I feel better, I'm just going to quit taking my pills. And we've seen them historically end up back in the hospital. Forgetting. That happens to me. So what do I use? I use a pill box. It's right on my bathroom sink. When I'm brushing my teeth, I'm going to take my blood pressure med, my multivitamin. It's sitting right there. Maybe friends and family need to help remind you. I had a pharmacy tech. You know, I had to set an alarm on my phone to remind her to take her metformin, her diabetes medication in the morning. Set those alarms. There's some actually websites you can go in, enter your phone number and the message you want to receive, and it will send you a text. You know, if you don't know, don't want to use the alarms, make it part of your routine. My dad's blood pressure medicine is right by the kitchen sink when he's filling up his little pot to make oatmeal every morning, and he doesn't miss that dose. The stigma. You are not alone in this. There are millions dealing with this and so many more that are not dealing with it. You know, as we're seeing again, organizations like NAMI, the White House, Institutes of Health coming out, community resources, just to identify and make it understood that there's help for you, help for them. I don't know that we really need to talk about storage. Just understand if it's a controlled substance, there are proper ways to dispose of it. Take it to the police station. Keep an eye and ear out for, medication take-back days. Most stuff you could throw it in the trash and some coffee grounds. If it is a controlled substance, I recommend probably flushing it or at least rendering it unusable. Because if somebody knows you take it or have access, they might want to dig through your trash.
Well, and I think most of the police stations now have drug boxes right in them that you can drop off anytime. Sure. And I wanted to mention this last bullet here. Do not take it back to the pharmacy. Okay. The pharmacy doesn't want it. It looks bad. There have been occasions where I had a patient come in with her husband's medications who just passed away. I'm not going to have disagreement with her. She's not in a state of mind. But I have to dispose of that in a certain way. We're not equipped within pharmacies to take the general public's
return medication. The best medication for you or your loved one is the one they will take, okay? Whether it be cost, side effect. My cousin's brother's roommate took it, didn't work for them. Well, if that is your rationale for not wanting to take the medication, then let's talk about it. Let's find something that will work. Again, as I'm doing this display for the presentation, I'm realizing that I don't have a way to type on the slide and still look at the video. So I'm going to write these down. And again, as time runs out, I know there's some in the chat. What I'm going to do is take these questions. Don, if you've got some you want to write down, or Robin, and email them, I will put them on the slide and then send this entire slide deck back to you guys.
That'd be great. That would really be great. And something that we always say to people that are that come to our events is sometimes you don't want to ask a question in front of everybody else. And as Joseph has shared, he will share his email address. So if there is a question you were not comfortable asking in front of a group, you know, don't be afraid to ask that question.
We do have a question in the chat right now.
Go ahead, Don.
It says, this may be beyond the scope of our discussion, but are any of the mood altering meds particularly appropriate for an elderly, early moderate dementia patient with lethargy, anxiety, and verbal abuse of caregiver with increasing meanness?
The one that stands out to me that you said was lethargy. So for the rest of the group, that is usually that kind of sleepy look, can't get out. So I'm just curious, you know, is it they are looking low energy, or, you know, we do look at depression. We do look at depressive symptoms among the elderly. Could be 2 or 3 things happening at once. So there have been occasions with lethargy where are we looking at a depressive state with low energy? They may benefit actually from an amphetamine. We have used very low dose in some of the elderly that just didn't want to get out of bed, off the couch, out of the chair.
And
now, sorry, go ahead.
Sorry, Joseph. They confirmed it, malaise more than lethargy.
Okay. So malaise could be the woe is me, maybe even having physical symptoms, perhaps like physical pain, soreness, could be depression. The psychosis and agitation is something different, widely seen in dementia patients. I will point out, like I did with the suicidality with the young people, which I never addressed, we'll get that real quick, is perhaps people that have already been thinking about it, they have an improvement in mood and energy on an antidepressant, and now they follow through with something they've been thinking about. It's not as if an antidepressant puts the idea in their head. The reason for the age cutoff is because we look at development of the prefrontal cortex. Kids are dumb and don't think through the consequences. So that's maybe why we're looking at a younger group more prone to a suicidal risk.
Thank you, Joseph. The other thing I'm going to say is for everyone to be aware of is the first 48 hours out of a hospital after a suicide attempt are the most dangerous. Because basically what Joseph was just saying, where they may not have had the energy or the ability to think through how the attempt, you know, how they were going to do it. Now their mind is clearer, and now they're, you know, and like you just said, Joseph, it may take weeks for an antidepressant to catch in. So at that point, it's those that you really got to watch somebody when they first get out of the hospital for something like that.
Sure. Now, as far as the antipsychotics, there is a black box warning that it is not to be used for dementia-related psychosis. That being said, they are very effective in treating sometimes the symptoms such as agitation. So they shouldn't be used as standalone treatment for dementia, which is again a very specific diagnosis. They would do better with medications like Namenda, for example. And again, treating that underlying aspect of be it malaise, lethargy, agitation, could be a UTI, could be nutritional. They have physical ailments, perhaps physical therapy, occupational therapy needs to get involved. They can't stand well. They've got back pain. They're on so many meds, their stomach hurts. You know, their mouth hurts denture-wise. They're not getting, again, appropriate nutrition. So I can't say that they would turn things around, but it is a possibility for treatment to use something like an antipsychotic.
All right. So at this point, we have reached 8 o'clock. I want to, Joseph, you're always so generous with your time, your thoughts, and everything that you share. Would everyone please join me in thanking Joseph for coming tonight?